Good afternoon, one and all. So today we are going to go into the second part of series on the surgical aspects of periodontics. So today we'll be covering the topic gingival surgeries. In this we'll be talking about two basic surgeries, that is your gingival curettage and gingivectomy procedure. Technical issues, just hold on. Well, the first topic which I'll be speaking is titled gingival curettage. So there are two terms here. One is curettage and then one is a gingival curettage. So curettage means it is a surgical scraping or cleaning of a tissue basically to separate a diseased portion from a normal portion. That is what is intended by the term curettage. Gingival curettage is related to the periodontium or the gingival tissues. So gingival curettage is again a surgical procedure which is designed to remove the soft tissue lining of the periodontal pocket. Most of the time we use a curette. So once we scrape out this pocket lining, it leaves only the gingival connective tissue lining. So that is what is meant by a gingival curettage. So curettage means it's a procedure which you are going to use a simple curette. Again, you know, curettes are the instruments which are intended for subgingival scaling and root planing and for this curettage process. So what is the rationale behind this gingival curettage procedure? So this is a pretty old treatment aspect, and the rationale is that after you do a supra and your subgingival scaling and root planing, what you do basically is you carry out this curettage procedure. So what it does basically is it reduces the pocket depth by two ways. Either it allows the shrinkage of the gingiva, or most of the time what we expect is basically a reattachment of your connective tissue. Also, what curettage does is it accomplishes a removal of chronically inflamed granulation tissue in the lateral wall of your periodontal pocket. So when I say lateral wall, it means the soft tissue wall of your periodontal pocket. So first you're going to do scaling and root planing, and then you intend to use this curettage process to have these two objectives. So most of the time when I say granulation tissue, the inflamed tissue which is present in the soft tissue wall of the periodontal pocket contains a lot of things. Of this, basically it contains the fibroblastic and the angioplastic proliferation. Along with that, it does contain a lot of pieces of dislodged calculus from the supragingival area, along with the plaque biofilms. Now, as long as these are going to stay in that area, basically it will not allow a proper healing to take place, right? And this is going to perpetuate the disease process. So that is the rationale of why earlier this concept of curettage was proposed and was used. Now we have some terminologies to deal with. Okay, so as I said, gingival curettage basically it is a scraping of the pocket lining or removal of the chronically inflamed soft tissue lateral to the pocket wall. There is another terminology which is called as the subgingival curettage. Now, what is this procedure? It is a procedure performed more apically, basically. Curettage is limited to the soft tissue lining, but in a subgingival curettage, what you intend to do is you carry this curette a little bit deeper along, extending up to the epithelial attachment and sometimes deep down to the bone, right? So that is your subgingival curettage. Then you have another terminology which is called as inadvertent curettage. Now, what does this mean? Now, when you are going to do a subgingival scaling, right? Most of the time you're going to use some sort of instrument. Most of the time you might use a curette. So your intention is to do a subgingival scaling and root planing, but what happens basically, there is some amount of curettage taking place, right? So there is a accident scraping of your pocket lining when you are doing your subgingival scaling and root planing. Now this is called as a inadvertent curettage, right? Okay. So when you see this diagram, okay, now when you extend your curate basically till this white arrow, it means you're going to do your gingival curettage, right? And when you extend this curate right till your connective tissue attachment, sometimes to your bone level, that is what you're doing, a subgingival curettage. So let's see what are the indications. The first indication is edematous and inflamed tissues. So edematous and inflammation tissues is as a result of your gingival inflammation. So whenever there is an inflamed tissue, you want to eradicate the source of inflammation. So you're going to do a supragingival scaling, and then you're going to do something called as a subgingival scaling, right? Now I'm using a older terminologies, right? So the terminologies have changed now. According to 2017 World Workshop, basically these terminologies have been eliminated, and nowadays we are going to use something called as a PMPR, that is professional mechanical plaque removal. Okay, so just remember this terminology, PMPR, that is professional mechanical plaque removal. So it can be a supragingival PMPR or it could be a subgingival PMPR. So once you're going to eliminate all the factors or the irritants which are responsible for this inflammation, you're going to eliminate the inflammation. That is the first indication. The second one is shallow pockets. So shallow pockets most of the time is not an indication for a periodontal surgical procedure, right? Like your periodontal flaps, right? So what you do basically in that situation is you're going to do a supragingival PMPR first, followed by a subgingival PMPR. Along with the root planing, you're going to debride the root surface. Then what it does basically is you're going to do a curettage along with that. That is going to eliminate most of the shallow pockets and revert the sulcus depth to a near normalcy. Suprabony pockets. Again, suprabony pockets and shallow pockets are almost of the time are the same. And so you're going to use this curettage procedure, right, with the intention that there is a resolution of inflammation, there's a shrinkage of the gingiva, thereby the sulcus depth reverts to near normal. And this curettage earlier was proposed to be as a part of your initial preparation, or what we call as the phase 1, prior to any surgical procedure like your periodontal flap. The reason is, as I said, the first indication is edematous and inflamed tissue. So whenever a tissue is inflamed and edematous, you will not be able to place a precise incisions, right? So, and then the second factor is it will bleed. It will just bleed and bleed and bleed. So we don't want those things to happen during a surgical procedure. So we want the tissues to be as healthy as possible, so that we'll be able to give a precise incisions. So this curettage serves that purpose. The last one is in medically compromised patients where surgical intervention is not indicated. Now let's assume that there is a patient who has got a shallow pocket or maybe a moderate depth pocket ranging from 5 to 6 mm. Then he has some medical systemic complications, and that makes him not a candidate for your periodontal flap surgical procedure. So in those conditions, what this curettage does is there is a repeated subgingival PMPR along with your curettage, so that the inflammation process are eliminated and the tissues reverts back to a near normalcy, even though it doesn't heal by a complete regeneration or by a complete attachment of your connective tissue, but still there will be inactive pockets, and that's what we want. Let's see what are the contraindications. The first one is a fibrotic tissue. So whenever you have a fibrotic tissue, basically you go in for more other procedure like your gingivectomy. And then when there are deep pockets, now you remember one thing, as the pocket deepens, it is very, very difficult for your instruments to reach to that deep levels. So you need a better access. That is where your periodontal flaps come into act. Furcation involvement. Again, whenever there is a furcation involvement, especially your grade 2 or your grade 3, then just by doing a curettage, it is not going to serve any purpose, because there are certain bony defects as well. So you require a surgical intervention there. The fourth one is treatment of any underlying osseous defects. So whenever there is any osseous defects, like either a 2-wall or a 3-wall, or a circumferential defects, vertical defects, right? So here, what we want is basically access to the surgical area, right, to that area for a procedure of regenerating the lost tissue attachment. So let's go into the procedure and see how this curettage is carried out. So, as I said, the curettage does not eliminate the causes of inflammation. What are the causes of inflammation? Your bacterial biofilm or microbial biofilm, right? So, what you're supposed to do is, first thing you're going to always do initial therapy, what is called as your phase 1, etiotrophic phase. You're going to do a supra and sub professional mechanical plaque removal, right? PMPR. And then you're going to carry out your curettage procedure. So the first and foremost thing what you're going to do is you're going to give an adequate anesthesia to that area, because you're going to do a little bit of invasive procedure using a curette going deeper down to your tissues. So always give a local anesthesia, right? It could be in a form of local infiltration or a regional block. So then what you do, the instrument preferred, as the word says curettage, you always have a curettes, right? So again, I keep telling, curette is an instrument used for subgingival scaling and root planing, and also for this curettage process. So as you know, curettes are of two types. One is a Gracie curette, also called as area specific curette, and then you have a universal curette. So you select a curette such that the cutting edge will be against the tissue rather than against the tooth surface or the root surface. If it is against the root surface, then obviously we will be doing a subgingival PMPR. So we want to place the cutting edge against the tissue so that we are intending to remove your soft tissue lining of your periodontal pocket, right? So here, when you see this clinical picture, what does it denote? When you see here, right, at the marginal gingiva, the tissues are quite erythematous. They look edematous as well, right? This means that this tissue is inflamed. When you see the same diagrammatic here, you see this is your subgingival area, the sulcal area. So you have a lot of local deposits here. Along with that, you have an inflamed soft tissue wall of your or the lateral wall of your periodontal pocket, right? So what you do? So as I said, first thing you're going to give some sort of local anesthesia. So you're going to give a regional block, or you're going to give local infiltration. Along with that, you're going to give papillary infiltration as well. Then what you do? You take a subgingival scaling instrument first, right? And then you're going to do your subgingival professional mechanical plaque removal, right? So when you see here, you're going to orient the blade against your root surface wall, right, or root surface, and then you're going to do your subgingival professional mechanical plaque control. Your blade is now towards your root surface. So obviously, you're going to do a root surface debridement. This is a radiographic finding. Again, you see the blade is oriented towards your root surface. Right now, you're going to carry out the same thing all across your tooth surface. Right, so you're going to go buccally from the mesial to the distal, and then from the mesiopalatal to the distopalatal, making sure that you're going to remove complete subgingival deposits. Right, so this is again the same thing. You're going to making sure that you're going to use and remove. Now you see the root surface has been completely removed of the local irritants. Right. Next, what you do basically is, as I said, you're going to take this curette, and then what you're going to do is you're going to make sure the cutting edge is towards your tissue wall, right? And you make sure that this is a cutting edge, so you're going to place the cutting edge across the tissues, and then with externally you're going to give a digital support. You're going to give support to the external surface of the gingiva, and you gently try to scrape out this entire pocket lining, right? So what you're going to do, you're going to place your blade against the soft tissue, and then externally you're going to place a digital support, and then you try to give a scraping motion. Right now, you may go from either a mesial to distal or from distal to mesial. That is based on your ease of use of the curette. Right. So what you see here is what I have explained, the rationale. This is your granulation tissues. Right. Right. So this is the granulation tissue, and you make sure that you're going to remove entire granulation tissue. Right. So the instrument, as I said, is engaged as deeper as possible, so that you're going to completely remove the soft tissue lining of your periodontal pocket. So most of the time, again, I said it could be used. It can be used from a distal to a mesial or from a mesial to distal. Most of the time in a horizontal stroke. Right now, this is again the diagrammatic description of this entire procedure. So this is what you're going to do. You're going to take a blade. I mean the curette, and the curette is basically placed against the soft tissues, and then you're going to scrape out this entire pocket lining. Right now, this is the soft tissue lining. So you're going to go along entirely till here. So what you make sure is that there is a raw connective tissue which is exposed now. Right now, what you're going to do after this procedure, you're going to give a little bit of force applied, right, external force applied, so that the tissue adapts to the tooth surface. Now, this is what basically is achieved by this curettage procedure. Now, this is the picture prior to your curettage procedure. As I said earlier, the tissue looks more erythematous, it looks edematous. And when you see this diagram, you see this red arrow mark basically shows the base of your periodontal pocket. There are a lot of subgingival deposits, as well as here there is a chronically inflamed soft tissue wall of your periodontal pocket. Now, once you finish this curettage procedure, what happens is, as I said earlier, the inflammation is resolved, and then what happens, that ultimately leads to a shrinkage of your gingiva. So what happens, right? So you see here, the red mark, which was the base of the pocket here, has now come to here. That means there is a shrinkage of the gingiva. This much of gingiva is shrinked. Thereby, there is a reduction in the pocket depth. So you see now the gingiva looks very healthy. It looks pink, and all the features of inflammation are now reduced or eliminated. Now, this is again a histological diagram, shows again two things. One, this is a curette basically. When the curette blade is oriented towards your root surface, it is intended to remove all these subgingival deposits. When this curette is oriented, the blade is oriented towards the soft tissue, and if it is taken in a coronal direction, then that is what is called as a curettage. Now, all this, what you see here, this is a chronically inflamed soft tissue wall or the lateral wall of your periodontal pocket. Now, this is a procedure again which was followed quite some time back, but short-term and long-term clinical trials have confirmed that this gingival curettage procedure as such does not provide any additional benefit when compared to your subgingival professional mechanical plaque removal. That means if you are going to do a thorough supra and subgingival professional mechanical plaque removal along with a root debridement, then the results obtained from these procedure is almost the same achieved by your curettage process. So that means there is less probing depth, some sort of attachment gain, maybe because of the shrinkage, and reduction in the inflammation. So what this American Academy of Periodontology, its guidelines for periodontal therapy, they said that this gingival curettage as a method of treatment is not indicated. That means this is obsolete, right? So this does not provide any additional benefit. So you're going to do just a supra and subgingival professional mechanical plaque control, that would be more than enough, right? Okay, so we'll just move on to the next procedure, that is called as excisional new attachment procedure, or what we call ENAP. Now, this technique, excisional new attachment procedure, was devised by Yukna in the year 1976. It is a definite subgingival curettage procedure, right, performed with a knife. Now, what difference basically is, what I'm telling you is the difference between your gingival curettage and your ENAP or excisional new attachment is simple. Curettage, you're going to use a curette. ENAP, you're going to use a knife. Okay, you might be using a scalpel blade, or you might be using some other gingivectomy knives. So what is this procedure? So again, this involves some sort of invasiveness to the gingiva. So we are going to use some sort of anesthesia. So it could be a local anesthesia, right, in the form of a local infiltration, or it could be a regional block, depending on the patient's comfort. So what you do is, the first one is you take a scalpel blade, number 15 or 11 blade. Then you're going to use an internal bevel incision, right? Starting from your gingival margin to the point below your base of your pocket. I'm going to show it in your diagram, diagrammatic this one, so that you will be able to understand it a little bit more. So this incision, the internal bevel incision, is again carried interproximally and lingually to retain as much as interproximal tissue. See, the idea is we want a complete closure of your interproximal area. Otherwise, again, there will be a dead space there, and then your healing will be hampered. So the intention is basically to cut the inner portion of your soft tissue wall of the pocket, right? This is the difference. In a curettage, what you have done is you have taken a curette and then you have scraped out the soft tissue wall. But here, in an excisional new attachment procedure, you're going to use some sort of knife or your scalpel blade, and the intention is the same. You are going to try to remove the soft tissue wall of your periodontal pocket. Now, once you excise this, basically the internal bevel, so you're going to take a curette and then you're going to thoroughly root plane the area. And you also make sure that this exposed cementum is the irritants, basically, or what we call the necrotic cementum, is totally removed, and a root surface which is smooth and hard in consistency is achieved. Then what you do, you're going to irrigate nicely. Then you're going to approximate the wound edge, and then you're going to suture and then give a periodontal dressing. As I said in the earlier lecture, right? Every surgical procedure, basically, you give some sort of periodontal dressing. So this is a diagrammatic or a pictorial description of this excisional new attachment procedure. So what you intend to do here, I'll just show you this diagram and then I'll go with the previous diagram, right? So here you have your subgingival irritants, deposits. So you're going to take a scalpel number 15 or scalpel number blade, and from the distance of some distance from your gingival margin, the crest of the margin, you're going to give an internal bevel incision starting from here till the base of the pocket. We assume that the base of the pocket is here, right? So you're going to give an internal bevel starting from here, gingival margin, right till your base of your pocket, right? So what it does basically, what is the difference from between gingival curettage and your ENAP is that here, when you see here, there is a sharp excision which has been done, right? So that means there is no leftover soft tissue wall as done in your gingival curettage. Remember, gingival curettage is a blind procedure. That means you're going to do it blindly by inserting a curette into your periodontal pocket, right? But here you're going to excise this entire pocket lining, making sure that you get an accessibility, right, and visibility to your root surface for a thorough debridement of the root surface area, right? So once you've done that, you're going to irrigate and then you're going to approximate both of this tissue by placing sutures, right? So this is what is called as excisional new attachment procedure. So along with that, you can also do this curettage procedures by using ultrasonic scalers. This is recommended, um, and it is very easy. Basically, instead of using a curette or if you intend to do hand instrument, you're using this ultrasonic scalers for supra and subgingival professional mechanical plaque removal, right? So along with that, you can do a very nice curettage uh, process. But again, the recent concepts says that whether you're going to use a hand instrument or you're going to use ultrasonic, if you're going to properly use it with a proper technique, both are as effective as the same. Apart from that, you can also use some caustic drug. This was the concept which was used earlier, right? So drugs like sodium sulfide, alkaline sodium hypochlorite, that is antiformin, and phenols were used in the past, but it is not used as such. This procedure is not used of late, but earlier they tried even caustic drug. They used to just inject this drug or just irrigate this drug into the pocket lining, thinking that there is a chemical curettage which happens, okay, and then it dissolves or it removes the lateral wall of your pocket. But then you never know the extent of this spread of this drugs. So again, it has got its own drawbacks, and that is why uh, this caustic drugs are not or never were followed in the future. What happens after you do a curettage process, healing after curettage? So once you remove the soft tissue wall or lining of your periodontal pocket, the pocket basically, it's not called a pocket no more. The sulcus basically is filled with a blood, and then it obviously forms a blood clot. A blood clot is replaced by your granulation tissue, right? Restoration and epitheliation of the entire sulcus usually takes between 2 to 7 days. Remember one thing, curettage again does not allow for a new connective tissue attachment. So it heals basically by a long junctional epithelium. Again, if the patient is not going to maintain his oral hygiene, this long junctional epithelium is very, very conducive to get again reinfected. So let's go to the next topic, that is your gingivectomy. So this is your second gingival surgical procedure. So what do you mean by gingivectomy? Gingivectomy means just surgical excision of the gingiva to remove the soft tissue wall of your periodontal pocket or your gingival pocket. Gingivoplasty, right? So plasty means reshaping. So it is a reshaping of the gingiva to create physiological contours. That is your gingivoplasty. So you should be remembering these two definitions. So gingivectomy means it is a surgical excision of the gingiva to remove the soft tissue wall of your pocket. Gingivoplasty means it is the reshaping of the gingiva to create physiological gingival contours. So let's see some of the indications of this gingivectomy procedure. The first one is elimination of suprabony pockets. So whenever there is a suprabony pocket, and if the pocket is the soft tissue wall of your pocket is more fibrotic, then that is a very nice indication for gingivectomy, right? So this most of the time is seen in a pseudo pocket, right, where there is then there is no destruction of your attachment apparatus, but still, but then there is a proliferation of your gingival tissues, making the sulcus depth more, right? That's what we call as pseudo pockets. So that is one of the indications of your suprabony of your gingivectomy. The next one is elimination of gingival enlargements. So whenever you have a situation like this, when you see here, right, the gingiva has enlarged. So again, gingival enlargement could be due to various reasons. It could be due to inflammatory, it could be due to drug-induced, it could be idiopathic, it could be caused by certain systemic conditions. So whatever the etiology is, if at all it is not amenable to your local or initial therapy, then this has to be excised. So again, gingivectomy plays an important role in eliminating this sort of clinical situations. The third one is elimination of suprabony periodontal abscesses. Abscess is a collection of localized collection of pus. But then if this abscess becomes a chronic, then what happens basically, you see here, the tissue becomes more fibrotic, right? So to eliminate these sort of clinical situations, we again use a gingivectomy procedures. Another indication is to expose additional clinical crown to gain added retention for restorative procedures. So here there is a clinical situation that there is a crown which has been badly broken down here, and there is no tooth structure here. So here obviously you cannot go in with a restoration unless you gain a more tooth surface for your crown preparation. So again here what we require is we are going to do a gingivectomy procedure to expose more tooth structure so that you will be able to do a proper restorative procedure. The next one is to create bilateral symmetry. Now here when you see here, there is a clinical indication for both. That means when you see the lower anteriors, there is an enlargement of the gingiva, which requires again a gingivectomy procedure. And when you see the maxillary anteriors, right, when you see here, you see there is a different level of your gingival margins, right? This is the margin here. We see there is a more apical placement of your margin here. So here it looks so anesthetic, isn't it? Right? So here this is another indication that you're going to do a little bit of a plastic procedure or a gingivectomy procedure to eliminate this much amount of tissue so that you create a bilateral symmetry. So again, this is one of the indication of gingivectomy procedure. Let's see what are the contraindications of gingivectomy. The first one is obviously infrabony pockets. If you have an infrabony pocket, right, you're going to use a periodontal flap surgical procedure rather than a gingivectomy procedure. When the bottom of the pocket is located apical to the mucogingival junction, if you are going to do a gingivectomy procedure, you are going to create a disaster, right? You're going to create more mucogingival problems. Inadequate oral hygiene maintenance by the patients. As I said in the previous lecture, when I was dealing with the indications again, I was telling that if the patient is not able to maintain a proper oral hygiene, then there is absolutely not an indication for any surgical procedure. So again, is not an candidate for your gingivectomy procedure. Medically compromised patients, uncontrolled systemic diseases, right? If the disease, systemic disease, well under control, then they are the candidates. But if they have uncontrolled systemic diseases, then they are not candidates for the gingivectomy procedures. And finally, as I said, uncooperative patients. If the patient is not going to cooperate, then obviously you will not be able to perform a good surgical procedure. So this gingivectomy technique may be performed by many ways. Number one, you can use scalpels, you can use electrosurgery, you can use lasers, and then finally, like in curettage, you can also use chemicals. So let's see what are the procedures for the surgical gingivectomy. So what are the instruments required? First and foremost thing, you're going to use something called as a Crane-Kaplan pocket markers. Right, I'll be showing you the picture of that. Basically, these are intended to demarcate the depth of your pockets so that you will be able to excise that much amount of tissue. Right. The second one is you're going to use gingivectomy knives. So gingivectomy knives are two types. One is a Kirkland gingivectomy knife, and then you're going to use Orban's interdental gingivectomy knife. I'm sorry, I think it's here, right? So gingivectomy knives are two types. One is a Kirkland, and then you have Orban's interdental gingivectomy knives. Along with that, either you can use a blade number 11, you can use a blade number 12, or you can use a blade number 15 as well. Then you're going to use curettes. Once you're going to excise these tissues, you may also might be using it for your root surface debridement. Along with that, you need to use tissue nippers or scissors to remove tabs of tissues, and also making sure that margins are quite trimmed and the contour are achieved. Normal contours are achieved. So this is what I have been telling you. This is the Crane Kaplan pocket marker. So on one side you have a straight end, and then you have a bent end. So usually this end, right, you're going to see here, this end is inserted into the pocket. And then what you do from this end basically is going to make a bleeding point, demarking the base of your pocket, right? So you have two pairs, one for the left and one for the right. So these are your gingivectomy knives. So you have your Kirkland gingivectomy knives, and then you have your Orben's interdental knife. So along with that, you can also use an electrocautery, right? So I'll be telling you in detail a little bit later what are electrocautery. So you can use electrosurgical method as well. So let's take this clinical scenario. Now the patient reports to you to a dental office or dental clinic in this situation. That means what you see here is a chronically inflamed gingiva with a enlargement as well. So here you're not going to straight away get into your act of gingivectomy, right? So before any surgical procedure, as I mentioned in the previous lecture, that you're going to do a thorough initial therapy, or what we call as a etiotropic phase. You're going to eliminate all the factors which are responsible for this inflammation. So what it does, I said, is it is going to render this tissue more firm, right? So that, you know, when you see here clinically, this is how it was prior to your supra and subgingival PMPR. So once you do a supra and subgingival PMPR, this is how the tissue will look like. Even though there is an enlargement of your interdental area, but still it looks more healthier and more fibrotic, right? So what it does basically is it is going to give you a clinical situation wherein you're going to place your incisions firm, continuous, and precise, right? This is what I said in the previous lecture. So again, what you're going to do, you're going to give some local topical anesthesia first, and then you're going to give a local infiltration, or you're going to give going for a regional block depending on the extent of your surgical area. Then what you're going to do is you're going to make sure they're going to take a air blower, and then you're going to blow the air to make sure that you know how much of tissue has been separated, right? And again, sometimes infiltration into the local infiltration of anesthesia into your papillary will also reduce the bleeding. So you're going to give interpapillary infiltration as well. So this is your Crane Kaplan pocket marker. As I said, you're going to insert one end into your pocket, and the other end is going to make bleeding points like this, right? So this is your site of your excision. This is you're going to excise. So right. So this is going to make bleeding points, right? This is how basically you're going to see this. Now again, what you're going to do is you're going to make it into a line. You're going to join all this line and make sure that your incision is going to be more apical to this bleeding point, right? This is how diagrammatically it is showing. Right now you have made a bleeding point, so your incision basically should be beveled at 45-degree angulation to give that normal contour. Understand, right? So this much area has to be excised. So you're going to start with your scalpel blade number 12, or you're going to use a blade number 11, or sometimes you can use, or most of the times you can use a Kirkland gingivectomy knife. So these incisions again can be a continuous incision, or it could be a discontinuous incision. It doesn't make a big difference whether you give a continuous or discontinuous. Again, it is how easy you are going to be using this incisions. So again, you're going to use something called as an external bevel incision, right? In the excisional new attachment procedure, you have used an internal bevel incision. For a gingivectomy procedure, the incision used is always called as an external bevel incision and oriented at 45-degree angulation. So you're going to take a Kirkland knife and you're going to orient it at 45-degree angulation, and you might use a continuous or a discontinuous incision and remove this entire tissue, right? So this is again a continuous incision which has been placed here, and you're going to use your Orban's interdental knife to release your interproximal attachments, right? For the facial attachments, you have used a Kirkland gingivectomy knife. To release your interproximal tissue attachment, you're going to use a Orban's interdental gingivectomy knife. Then you're going to use curette, and then you're going to do a nice root debridement, right? There are a lot of, you see a lot of local factors here. You're going to do this root debridement. And then what you're going to do is you're going to use your electrodes for a gingival contouring process. You're going to get back to that normal physiologic contours. Otherwise, what happens basically, there'll be a step-like thing, and that is going to again accumulate plaque and then lead to recurrence of your the same problem. Sometimes you can use certain local drugs to this area, right? And then you're going to cover it with your periodontal dressing. And this is how it will look after about, let's say, about 4 to 7 weeks, completely healed. So this is what I said again, repetition, right? You're going to insert your crane Kaplan pocket marker. This will get into the depth, and then externally you're going to make a bleeding point, and then you're going to give an incision more apically to this bleeding point. So again, incisions could be continuous as shown in this diagram, and you can give this is discontinuous, starting from the distal aspect here, extending to the mesial of a papilla. Again, then you're going to give starting a new incision from the mesial of this papilla to the distal of this papilla, right? Or you can give continuous incisions like that. Now these are the bleeding points. So the bleeding, the incision basically is placed more coronally to your bleeding points, right? So these continuous and discontinuous was advocated by two people. One is by Robisek and then one by Zentler. So again, this is just a description. I put it in words. So what you're going to do, you're going to check the pockets on each area with a periodontal pocket, or if you are having a crane Kaplan pocket marker. Once you create bleeding points, again, you can use a continuous or a discontinuous incisions. The incision should be beveled at 45-degree angulation, and this incision is called as an external bevel incision. Along with that, you can use either a Kirkland gingivectomy knife, or you can use Orban's interdental gingivectomy knife to release the interproximal attachment. So once you're going to remove this, what you're going to do is you're going to completely do a thorough subgingival root planing to remove all those root irritants, then irrigate nicely, and then make sure that you're going to remove complete granulation tissue and remaining any calculus or necrotic cementum. And then you're going to, most of the time, apply some sort of medicament and then cover the area with your periodontal dressing. So this is what I discussed so far is your surgical method. You can also do gingivectomy by using something called as an electrosurgery. So electrosurgery is a surgical technique performed on a soft tissue using controlled high frequency electric currents, the range of 1.5 to 7.5 million cycles per second. So there are 3 types of electrodes which are available along with this electrosurgical kit. So you have a single wire electrodes which are used for incising or for excising. You have a loop electrodes for planing the tissue or for giving that contouring the gingiva. The third one is heavier, bulkier electrodes which are intended for use for any coagulation procedures whenever there is an excessive bleeding, right? So this is your electrosurgical unit, and then you have, as I said, different sort of electrodes. So you have your straight electrodes, then you have your loop electrodes, and then you have your bulkier electrodes for coagulation. So apart from that, one of the main key takeaway from this electrosurgical is that during a normal surgical method, there will be excessive bleeding. But whenever you're going to use electrosurgery or especially laser, the procedure is entirely bloodless. So laser also can be used for gingivectomy procedure. So the different type of lasers which can be used, you can use either a carbon dioxide laser, you can use a Nd:YAG lasers. Latest in our clinics we use a diode laser. Just like your gingival curettage, gingivectomy was also performed by using certain drugs such as 5% paraformaldehyde or potassium hydroxide. But then you never know what is the extent, so it is not again currently used. Next, we come to the gingivoplasty. So gingivoplasty is defined as the recontouring of the gingiva that has lost its physiologic form. This was described earlier by Goldman in 1950, and Sugarman in 1951 was the first person to use electrosurgery to do a gingivoplastic procedure. So what is the objective of this gingivoplasty? So you remember the objective of gingivectomy was to eliminate the pocket by removing the soft tissue wall. But here gingivoplasty basically intends to reshape the gingiva to create normal physiologic contour in the absence of pockets. So gingivoplasty basically is intended to create normal physiologic contours. So what are the indications? The first indication is whenever there is a need for correction of grossly thickened gingival margin. So whenever there is a gingival margin which is thick, basically, it doesn't look aesthetics, and also it might create a area where it is conducive for a plaque to accumulate. So we need to do some procedure called as gingivoplasty to get back that normal contours. The second one is gingival clefts and craters as a result of necrotizing ulcerative gingivitis. So whenever there is a necrotizing ulcerative gingivitis, it creates certain sort of clefts and craters. So it looks aesthetic, anesthetic, and as well it is a site conducive for accumulation of bacterial biofilms. The third indication is varying levels of gingival margins. So when you need to create a bilateral symmetry, you can do a gingivoplasty procedure. So what are the instruments through which you can do a gingivoplasty? Is you can use gingivectomy, you can use periodontal knives, right? You can use scalpels, you can use rotary coarse diamond stones or burrs, you can use electrocautery, and you can use lasers for this gingivoplasty procedure. Let's see how this tissue heals after you perform a gingivectomy. So the first and foremost thing, just like your curettage procedure, right? The first thing is there is a bleeding and then there is a clot formation, and this clot is immediately replaced by granulation tissue. So by 24 hours, there is an increase in the new connective tissue attachment or new connective tissue cells. The epithelial cells start to migrate over your granulation tissue, and by the third day, fibroblasts are seen. After 5 to 14 days, surface epithelialization generally is complete, and it takes roughly 1 month for a complete epithelial repair to take place. And as a whole procedure, that means complete epithelialization as well as a complete repair of your connective tissue roughly takes somewhere to 7 weeks, right? So this finishes the topic on the gingival surgeries. So again, to summarize, we dealt with two procedures. One is your gingival curettage, and then one is your gingivectomy. So curettage, as I said, is nothing but scraping of your soft tissue wall lining of your periodontal pocket, right? So you use curettes to do that procedure. So again, you have gingival curettage, then you have subgingival curettage, and then you have your inadvertent curettage. So again, you're going to give some sort of local anesthesia. You're going to take a curette. You're going to insert it as deep as possible, making sure the cutting edge is oriented towards the tissue, and with a digital pressure from the axial surface, you're going to scrape out the entire pocket lining, right? That is what curettage is, right? And then we said that according to long-term and short-term studies, there is not much benefit which derives between your regular supra and subgingival professional plaque removal versus your curettage. So the American Academy of Periodontology has removed this treatment protocol as such. So that is what is about gingival curettage. Then we spoke on the excisional new attachment procedure. As I said, it was devised by Yukna, and then it usually uses a knife. Okay, that is what differentiates between ENAP and your curettage. And then I said that you can use ultrasonic scaler to do this curettage procedure also. Gingivectomy, as I said, basically can be is a surgical excision of the gingiva to remove the pocket wall of your pocket. So again, gingivoplasty is the reshaping of your gingival contours. So you can either do by using a surgical method, you can use electrosurgical method, you can use lasers, and you can use a chemical method as well. And the incision used for gingivectomy is called as an external bevel incision, and you can use it either by using a continuous or a discontinuous incision. So the instruments used are Payne Kaplan pocket marker, which is used to delineate the pocket depth. Then you can use gingivectomy knives. You can use scalpels. Then you use curette to do a root debridement, and then finally place a gingival, periodontal pack. Okay, right. So this finishes the topic. So we will be continuing lecture on periodontal flaps in the next lecture. So hope you understood what I have said. If you have any doubts, please go through the topic once more, and you are welcome to come up with your doubts in person, right? Okay, have a good day.